Welcome to this short review of type 1 hypersensitivity, anaphylaxis, and immediate reactions. I'm Christopher Lee, and in this video, we will answer one of life's great immunological questions. Are anaphylactoids stronger than a breath mint? Well, okay, maybe not, but we will clarify what type 1 hypersensitivity is, why it can become life-threatening, and why anaphylactoid reactions can look very similar clinically. Let's start with a real case. This patient developed signs consistent with an immediate hypersensitivity reaction. Type 1 hypersensitivity includes immediate mast cell-mediated reactions. Anaphylaxis is a severe systemic form and can be fatal if not recognized quickly. For clinicians, the major goals are to recognize the pattern, understand the mechanism, and know why treatment needs to happen fast. Type 1 hypersensitivity is classically driven by IgE antibodies bound to mast cells or basophils. Usually there is a first exposure called sensitization. Often that first exposure may not cause obvious clinical signs, but it can lead to the immune system to generate IgE. That IgE then binds to receptors on mast cells and basophils. After sensitization, a short or long period of time may pass before the next exposure, sometimes years. Then, on a later exposure, the antigen crosslinks IgE on the mast cell surface, and wham! That crosslink triggers degranulation and release of inflammatory mediators such as histamine, leukotrienes, prostaglandins, platelet activating factors, and cytokines. Those mediators drive the clinical signs, which is why type 1 reactions can happen quickly, often within seconds or minutes after exposure. You may also hear the term anaphylactoid. This is an older term used for a reaction that looks clinically just like anaphylaxis, but does not require the classic IgE-mediated sensitization. So anaphylactoid does not mean stronger, weirder, or even extra minty. It means that the clinical syndrome resembles anaphylaxis, but the initiating mechanism may not be classic IgE cross-linking. Today, many sources prefer language such as non-IgE mediated anaphylaxis rather than anaphylactoid. For the clinician, the key point is that these reactions can look very similar, and emergency recognition and management may overlap. Clinical signs vary by patient and by species. In dogs, we often think of facial swelling, urticaria or those hives, vomiting, diarrhea, collapse, and shock. The Frenchie from the opening case is a classic visual example of facial swelling and hives. Cats may also vomit, but respiratory signs can be especially prominent. They may be present with dyspnea, respiratory distress, collapse, or shock, and they may not show the dramatic hives we expect in dogs. This matters for staff training. If a client calls after a vaccine visit and says their cat is vomiting or breathing abnormally, this should not be dismissed and say, just watch him. That cat needs to be evaluated. This brings us to the idea of shock organs. A shock organ is a teaching concept for the organ system most prone to clinically important dysfunction during systemic shock in a given species. It is a useful shorthand and not an absolute rule. In cases of shock, dogs are the memorable exception, as dogs are classically associated with GI and hepatic patterns, while cats, horses, and cattle are often taught with a more prominent respiratory involvement. The point is not that only one organ system is affected. The point is that the same systemic process may look different across species. Anaphylaxis is primarily a clinical diagnosis. This sounds simple, but it's not always easy. Veterinarians often use diagnostics to support the pattern and to rule out other problems. In dogs, blood work may show hemoconcentration or an elevated ALT, with other values relatively normal. Those findings can support the diagnosis in the right clinical context. AFAST can also identify gallbladder wall edema sometimes called the halo sign. But there is often a time delay between the onset of anaphylaxis and the development of those clinical pathologic changes, so early results may not tell the whole story. The gallbladder halo sign can be helpful, but is not pathognomonic for anaphylaxis. It should be interpreted with the history, the timing, physical exam, and other diagnostic findings. So the halo sign supports the story, but it does not replace the story. Benadryl or diphenhydramine often gets over-relied upon. It can help block H1 histamine effects, so it may reduce some histamine-mediated signs, like hives, pruritus, or some swelling. But type 1 hypersensitivity is not just about histamine. Mast cells release multiple mediators, including leukotrienes, prostaglandins, platelet activating factor, tryptase, and cytokines. So diphenhydramine is an adjunct. It is not the cornerstone of treatment for active anaphylaxis. The cornerstone drug, the one I care about most in an active anaphylactic emergency, is epinephrine. Epinephrine supports the blood pressure and perfusion, reduces airway edema, bronchodilates, and helps blunt ongoing mast cell degranulation. I sometimes explain the treatment plan to clients as 3 distinct time zones: the past, the present, and the future. Epinephrine is for the present. It addresses the emergency happening right now. This is the drug that can stop the train while it's actively coming off the tracks. Dexamethasone is for the past. It helps address some of the inflammatory damage and aftermath from the reaction that has already been triggered. It is not the emergency brake, but it can help reduce the inflammatory consequences after the initial cascade has begun. Diphenhydramine is for the near future. It blocks H1 histamine effects and may help reduce hives, itching, and swelling, or the recurrence of some histamine-mediated signs while it's in the system. But it only addresses one part of the mediator picture, so it does not replace epinephrine. And of course, if the patient is in active shock, they may need hospitalization, IV fluids, oxygen, additional treatment, and monitoring. To summarize, type 1 hypersensitivity is an immediate, often IgE and mast cell mediated reaction. In the classical pathway, prior exposure leads to IgE production. That IgE binds to mast cells. Then, on a later exposure, antigen crosslinks IgE, triggering degranulation and mediator release. When this becomes systemic and severe, we call it anaphylaxis. Clinical signs vary by species, and diagnostics can support the pattern, but recognition depends upon the history, timing, and clinical picture. Thanks for watching. I'm Christopher. What you understand today helps you protect patients tomorrow. I'll see you in the next video.